Very good morning to all of you. Thank you, Dr. ANITA, for the kind invite. Respected chairperson, seniors in this profession, and dear friends. Next 15 to 17 minutes, I would be talking to you regarding metformin in gestational diabetes management. I have no disclosure to make. This is a controversial topic, which I think you will learn to know. And I will be talking briefly upon the important aspect of the drug. So I will be touching on the rationale, why we should use metformin in gestational diabetic, a brief account of pharmacokinetics, effect of metformin on maternal outcome, on fetal outcome, long-term safety data, concerned with fetal exposure to metformin, and few case presentation, few trials, and the clinical guidelines. We know that the world is experiencing epidemic of type 2 diabetes, and substantially large number of females is having gestational diabetes, which is between 3 to 25%. And 85% of gestational diabetic can be managed by medical nutritional therapy, lifestyle modification. And only 15% they require treatment. And insulin is the drug of choice. And metformin was being used since 1970 in South Africa. When I did my post-graduation in late 80s, my professor used to give sulfonylurea, especially glibenclamide and metformin for the gestational diabetes treatment. So there are sufficient data regarding the efficacy and short-term safety of metformin in the treatment of gestational diabetes in relation to the maternal as well as neonatal outcome, and its beneficial effect on less of maternal weight gain and also on macrosomia and neonatal hypoglycemia, apart from the fact that it is easy to administer, it is cost-effective, and it doesn't need much of logistics, like doing blood sugar monitoring round the clock. And the thing is, it is universally accepted fact also. The concern regarding metformin is that it crosses placenta. So we have to keep it in mind, its teratogenic and embryopathic effect. It acts through cellular energy depletion. So it can affect probably the fetal programming, and we don't have a data on long-lasting effect of metformin in the offsprings of the mother who had taken metformin during their pregnancy. What is the rationale for using metformin? We know that type 2 diabetes is associated with increased insulin resistance. Metformin decreases insulin resistance, thereby increasing the insulin sensitivity. It increases peripheral glucose utilization. It decreases hepatic gluconeogenesis. As a result of which, there is decrease in the glucose level, decrease in body weight, and decreased risk of hypoglycemia. As pregnancy advances in the mid and late gestation, means second and third trimester, what we see is increase in the insulin resistance because of the diabetogenic effect of the placental hormones. So insulin resistance increases. So adding a metformin probably would help decrease insulin resistance, because metformin acts through a different way. It decreases insulin resistance, and secondly, it does not cause hyperinsulinemia. So it's a better choice in late pregnancy as well. So when we talk, hypothetically, the drug of choice during pregnancy would be metformin. Coming to the pharmacokinetic consideration of the metformin, it is a hydrophilic drug, positively charged biguanides, and it requires a transporter proteins to cross the membrane. So it is organic cation transport, which is 1, 2, and 3, which is expressed in the placental tissue, and there is bidirectional flow of metformin from maternal side to fetal side, and fetal side to maternal side, and more from fetal to maternal side. And the concentration of metformin at a point of time is 50% of that of maternal concentration. And at the time of delivery, it was shown that the umbilical cord concentration of metformin varied from 0, that is from 5 nanogram to 1,263 nanograms. As pregnancy advances, there is increase in renal clearance by 29%, so we may need more of the drug. Requirement maybe anything between 500 to 2,500 milligram, and metformin is secreted into breast milk, and it is 0.3 to 1.3 milligram per day, so not so significant. So, coming to the effects of metformin on maternal outcome, most of the trials have shown that there is no adverse outcome. There is a lower weight gain, lower pregnancy-induced hypertension, less of hypoglycemia. Metformin in PCOS has shown there were less of pregnancy loss and preterm deliveries, and there were less of congenital malformation. Coming to its effect on fetal outcome, it is largely favorable. Lower mean birth weight, decreased macrosomia and LGA, less of hypoglycemia, less of ICU admission, but the prematurity was high in metformin. Long-term safety data of metformin use in pregnancy shows that during pregnancy there is significant fetal exposure. Long-term effect of exposed offspring are currently unknown. Exposure to hyperglycemia may cause increased obesity, diabetes in adulthood and adolescent. Metformin may even improve fetal insulin sensitivity. According to metformin in gestational diabetes, the offspring follow-up trial had shown that the central fat distribution was almost similar in both the group, metformin as well as insulin group. What are the concerns of fetal expression to metformin? It is important to determine the embryopathic and teratogenic effect of metformin, and the action of metformin is through the increase in the activated protein kinase level, which mediates several metabolic effects of metformin on glucose and lipid metabolism. It causes oxidative stress in the embryo and stimulates AMPK, and this causes lesser of gene expression, especially the PAX3, which is important for neural tube closure. So probably it may have a teratogenic effect if the AMPK level is increased, but it has not been proved. It acts on 1C pathway, which is of concern for protein synthesis. It has got an antifolate and B12 deficiency activity. Lee et al. In 2014 has demonstrated decreased PAX3 expression in vitro of the mice with the metformin exposure, but which has not been seen in vivo trials. Coming to few randomized control trials, meta-analysis and observational trials, studies both prospective and retrospective. The largest trial was done by Rowan et al. In 2008. It is called metformin in gestational diabetes, and it was 751 females participated between 20 to 33 weeks of gestation, and they were given 2 grams of metformin. And it was done to rule out the 33% increase in composite of perinatal complications in the infants of the mother who were taking metformin. And the primary outcome was neonatal outcome, and the secondary outcome was maternal, and the anthropometric measurement in the neonates. And the results were very encouraging in the sense that there were no increase in the composite perinatal complication. There were less of neonatal hypoglycemia. It was accepted more. There were, of course, preterm births, and 46% of diabetic females who were in metformin required insulin. The same was the reports from the RCT trials by Izaz, Niromanesh, Hassan, Tertai, and Spolensky. The observational trials also has shown comparable equivalency with metformin, but they had shown that the preterm deliveries were less compared to Rowan et al., who has shown that preterm deliveries were more. There were less of macrosomia, lesser maternal weight gain, better glycemic control with metformin. The meta-analysis done by Gu et al., who had taken 5 RCTs in 2014, and Su et al., who has taken 16 for 6 RCT, they also had shown a significant and better outcome with metformin. Now I will be talking about few cases. The case number 1 is Gayatri, a 27-year-old pregnant female with a BMI of 26 was diagnosed to have a gestational diabetes at 24 weeks of pregnancy with a fasting sugar of 103, and her OGTT after 2 hours was 150 milligram. She had a strong family history of diabetes. Both her parents were diabetic. And one of her sisters, she also had a gestational diabetes. So how do we manage this patient, whether to start on metformin, insulin, or combination? We know we have to give her MNT at least for 2 weeks before starting on any medication. So she was given 2 weeks medical nutritional therapy, lifestyle modification for reduction of weight. And after 2 weeks, when the fasting sugar was done, it was 99, and the postprandial was around 117. She was put on to metformin. It was started with 500 milligram per day and was increased. By the end of 3 weeks, it was 1,500 milligram of metformin was given. Her blood sugar was 93 fasting, and the postprandial 2 hours was 110. So coming to patients who may not respond to metformin, especially more obese patients, higher baseline fasting, early detection of gestational diabetes, higher baseline HbA1c, past history of gestational diabetes, and the biggest limitation metformin is failure to achieve optimal glucose because 10 to 46%. Balani has shown 10%. Rationale et al. Has shown that 46% may require additional insulin supplementation. So metformin can be used in mild hyperglycemia during pregnancy. Case number 2 is Stella, 32-year-old female, non-diabetic, a known patient of PCOS on metformin. She conceived on metformin, and she was diagnosed to have gestational diabetic at 28 weeks of pregnancy with a fasting of around 110 and postprandial OGTT at 2 hours of 140 milligram. So how do we proceed? Do we want to continue metformin in this patient, or we should take off metformin from her and add an insulin? There have been good number of randomized control trials regarding PCOS, metformin, and gestational diabetes. The largest one was by Venki et al. In 2004 and 2010, where he has compared. It was 0 to 32%. That is, the complication did not occur at all in patients who were on metformin arm, and there were 32% complication which seen in the placebo arm. So the pregnancy-related complications were less, and there were less of preterm deliveries. Begum et al. In 2009 had shown there was 9-fold lesser risk of developing gestational diabetes, 3 compared to 30. In the arm which were taking metformin, only 3% developed, but the control group, 30% of them had developed gestational diabetes. Mori et al. In 2012 has shown that patients who conceived on metformin had higher live birth. So observational studies also had shown equivalent outcomes similar to randomized control trial, lesser early loss, and there was significant reduction in the GDM conversion. So this was the second case. The third was is Aruna. She is 34-year-old female with 28 weeks of pregnancy with GDM. Fasting is 113. 2 hours OGTT is 165. She was put on insulin 3 times a day, short acting, and she had insulin N at night time. Her sugar was not controlled. Any beneficial effect of adding metformin? Yes, according to the trials that we have, that I spoke, the insulin resistance increases as the pregnancy advances, especially in the mid and late trimester, where the insulin resistance is increasing because of the diabetogenic nature of the placental hormones. So insulin, metformin may help. In the Rowan study, they have shown that the dosage of insulin required was 15 units, but those in whom metformin was used, there was decrease by 8 units of insulin. So we can definitely add in the later pregnancy metformin because it improves insulin sensitivity. The last case is Priya. She is an elderly primary, 31-year. BMI is on the lesser side, 22. She had 18 weeks of gestation, having very fasting of 115 and 2-hour OGTT of 175 milligram. How do you proceed? There is no question. We have to put her on insulin. Why? Because the guideline says the insulin should be considered as the first choice of treatment for gestational diabetes if it is diagnosed before 20 weeks of gestation. Secondly, if the need for pharmacological therapy is for more than 30 weeks, if the fasting is more than 110, The postprandial is more than 140, and the pregnancy weight gain is more than 12 kilo. Metformin is not approved currently by the FDA. It is listed as category B drug. The International Association of Gynecologists and Obstetricians and Gynecologists, the NICE guidelines, the European Society, they all approve insulin, glibenclamide, and metformin as first line of drug. The American Congress of Obstetrics and Gynecologists, ADA and IDF, is insulin is the drug of choice. According to the consensus statement of 2020 ADA guidelines has said again and again that insulin should be the first drug of choice for managing gestational diabetes. So comparing insulin and metformin, what we see is the higher cost of the drug. Multiple injections are required when you use insulin. We have to do frequent SMBG, greater time by healthcare professionals, where we have to teach the patient, we have to spend a lot of time, we have to adjust the dose of insulin. It is cumbersome for some patient, they cannot. There are a lot of logistic problem because in resource limited area, of course, we have to use some other drug, but where you cannot, the cold chain has to be maintained, it has to be, so a lot of logistics are required when we use insulin. So they need more visit to the hospital. There are increased chances of hypoglycemia. So to conclude, metformin decreases insulin resistance in gestational diabetes and PCOS. Its role appears truly encouraging. Metformin is effective and when tolerated glucose lowering agent in pregnancy, very low hypoglycemia, safe in pregnancy, can be used as single drug in milder form of hyperglycemia. And metformin is far less expensive, convenient, and acceptable. With increasing diabetes among reproductive aged women, it is likely that metformin use will increase. Thank you for a patient hearing. I invite all of you to the ACPCon Kochi 2020, that is American College of Physicians India Chapter National Meeting, which will be held in Hotel Grand Hyatt on 21st, 22nd, and 23rd of August 2020. Thank you very much.